Hello, and welcome to Cannabis, the podcast. I'm your host, Dr. Tori Rerick. Each episode will feature a candid conversation about how the cannabis plant has positively impacted individuals' wellness and bliss. Here to honor the plant and have fun. Hi, everyone. Welcome back to Cannabis, the podcast. Tonight, we have Dr. Melani Kane on. She is a cannabis pharmacist and, of course, patient advocate. So she graduated from the Philadelphia College of Pharmacy. Then she returned to Minnesota as a cannabis pharmacist. And because she was dissatisfied with the plethora of misinformation available to healthcare providers and the public, she created PrepCann to prepare healthcare professionals in their role with cannabinoid medicine. We're also going to touch on tonight that the society she founded, American Society of Cannabis Pharmacists, to encourage pharmacists to provide their unique perspective and expertise on the subject. Is there anything I'm missing? Anything you want to add, Dr. Kane?
That about does it. Thank you so much for having me. I love talking about cannabis and I love talking about it with pharmacists.
Right off the bat, what was your first experience with cannabis? What were your original perceptions of the plant?
Absolutely. So focusing on it as a therapeutic tool, I was really introduced to cannabis in 2013 when I attended this conference on alcoholism and chemical dependency. And it was at this conference that I was able to really join AA meetings and Al-Anon and NA. And I saw the perspective of the user and the addict. And I thought, how close pharmacists are in the communities. We are physically giving these drugs out, whether they're opiates or benzos or opioid alternatives. And it got me thinking, how can I help those that are addicted versus those that are diverting and, doing not so great things? And I realized there's no way of knowing. Look at the status of our healthcare system. Pharmacies are drive-through.
Right.
And it feels as though pharmacists have been, pushed away from the actual patient care. And, I acknowledge that a lot of states are on the up and up and that they are improving those relationships. But, it made me realize that there's only so much I can do behind the counter and behind, that bulletproof glass. Like,
oh my gosh.
I went to pharmacy school in West Philadelphia, so quite familiar.
Yeah.
So after I learned about cannabis, I went back to pharmacy school and had more years to complete. And I was really interested in pursuing additional education, postgraduate work to really solidify clinical experience, directly dosing with patients. And I didn't end up getting any recognized program. So I had to enter the workforce, and I came across this position as a dispensary pharmacist. I'm like, yeah, that's what we do. We dispense. I love it. And when I found out it was, specifically dispensing cannabis in my home state, Minnesota, where pharmacists are legally required to both dose and dispense. And I thought, wow, this, couldn't have been an accident. I truly believe things happen for a reason. And if they're not working out, then it's not the end of that thing.
Totally.
So I ended up applying, and I actually applied twice. I did not get it on the first go. Then I reworked my cover letter and I sent it back. And then I got an interview. Yeah. And, I'm reading as much as I can about the laws, because I feel like, and I still feel this way, with any pharmacist role, you need to know the laws that govern you. This is, at a bigger standpoint, this is where reimbursement would play a role. But, in this case, it's where the legal control and that aspect of the DEA and all that oversight. So I was, I read up on all the laws. I read up as much as I could about Minnesota specific programs so that I could really connect better with the dispensary owners. And I got the job.
Yay!
Yeah. So I was very shocked. It was my first job out of pharmacy school and I loved it. I really thought I would do it forever.
That's so amazing. I can't believe you hit the nail on the head. I'm jelly.
Oh, thank you. But it was hard, nobody knew how to
Mm-hmm.
dose. I remember, we had this MSL that was going and educating physicians in our state. And she comes up to me and says, why are you using these products? It was like in a support group that we had. She's like, why are you using these products for, Parkinson's and what was the other example she gave for like insomnia? Like I thought, the THC was just for pain. I'm like, no, 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 no.
Mm-hmm.
That's how you get in trouble with the FDA.
Exactly.
You don't treat, diagnose, cure, prevent, or mitigate diseases. However, symptoms could also be seen as different or a supplement. So,
Right.
we talked about how every body responds differently and uniquely to cannabis. And I think that's what healthcare professionals are so afraid of. They
Mm-hmm.
like control. They like that, you know,
It's
it,
an intuitive thing to be in plant medicine.
it truly is. And I think that's your LinkedIn
Yes. I'm
thing. I
all
saw
about
that.
the
I was like, wow, okay. You don't see that often.
surprise.
I've
But
seen integrative pharmacists and I'm like, that's
right.
cool.
Right. I'm more on the spirit side of things. And so I want to rewind for a couple of things here because maybe we've crossed paths before. Are you talking about the Utah School of Alcoholism and Drug Dependency?
I am.
I
With
attended that
HPHA.
too.
Oh, I love it.
And it may have been the same year. I'd have to look back, but that changed me. I mean, I've always had this connection to mental health, addiction, all of that, just personally, and curiosity about it. The show Intervention was a big hit, and so to be accepted to go to that school was a big deal, and it was so eye-opening. And I wish that every pharmacy student could attend.
Yeah, that's amazing. I'm truly impressed right now. I remember there was a speaker there who was a police officer from I think he was from like
New
Arizona,
Mexico? Okay.
New Mexico, somewhere there. Yeah. Oh my God. Yeah. And he was like, medical programs are just a joke to get people high. I'm like, I got so emotional that I just got up and left.
My
They're
God.
like, are you okay? Are you having a moment? I'm like, yeah, that guy is dumb. Why is he up there?
Totally. And I was just taking everything in. I had no connection to cannabis at that point. I really wasn't an advocate for it then. I just wanted to absorb the information. So I was just taking it all in. But it's really interesting that you had this, again, intuition to be like, this isn't something I jive with, because in pharmacy school, my experience was just receive information and accept it. Not really challenge it. So, wow, really bold of you.
Yeah, I remember this, the last 2 years of my pharmacy school were focused on therapeutic classes and, learning the body, the disease, and how to treat it with a drug. And there was this metabolic block, I think is what we called it, where it's we started with blood pressure, we talked about cholesterol and diabetes, and there's a few other things that they snuck in there. And then the very last section of that block was stroke. And the professor starts and says, everything you've learned this year up until now has been to prevent what we're about to talk about, and it just made me think okay, well, how about instead of just treating a drug with everything and, potentially just masking the symptom, why not actually go through and figure out what's causing the high blood pressure? Is it diet? Is it stress? These are things that we ignore because it takes more work. And our healthcare system is not based on outcomes. It's a very profitable, lucrative system.
Mm-hmm.
I'll give it that.
Mm-hmm.
But, the dollars we spend don't match the outcomes we're looking for. So,
no.
I'd like to see greater rebellion.
Right. And I'm so appreciating you saying that.
But, with cannabis, I don't tell people, you must take this dose 3 times a day. You can't do that. You have to guide patients to help them listen to their own bodies. Exactly. And, I think I learned this really quickly in pharmacy school. People don't come to the pharmacy because they're feeling good. Mm-hmm. And the ones that do come and know that they can ask their pharmacist questions about, I've got some heartburn. Is it, best to treat this with Zantac or ranitidine, or should I use omeprazole, or, what Prilosec, what should we be doing? And it made me realize that, that's what cannabis is. Cannabis is a symptom manager, and that's how we can easily use it in pharmacies. Now, if you're looking for very specific, chemotherapeutic effects where you probably need some consistency in your dosing. And it's much more important when it comes to stability and consistency. That I would highly recommend, more specific products that have undergone FDA rigorous testing for, probably as a botanical drug like Epidiolex, but, ensuring that it is safe for that use and it can actually have those benefits as touted. But, with symptoms, like it pains me to see that our communities are suffering and we have this amazing plant that is literally here to make us feel better. And yet we demonize it because it's mind altering. Sugar is mind altering.
Oh my gosh.
We subsidize our sugar beets.
Everything we dispense is just like, it's up there. You can't separate anything out.
Absolutely.
You know what I mean?
And I've since transitioned out of the dispensary. I'm there, I'd say once every 2 to 3 months, but
okay.
Definitely something I still enjoy doing. It's hard to find time.
Totally.
But yeah, the other things I do related to cannabis consulting.
Okay.
I'll start with the association because that's our biggest baby. I actually co-founded it with a University of the Sciences alumni, Dr. Christine Rousseau. And there's actually 3 women together that when we started this, and it was just amazing to see women coming together. We do dominate the pharmacy field, but specifically only the female plants really produce the medicine. And, I'm in that role as I'm currently president of the board of directors and the executive director. And there's so many pharmacists that reach out and say, we feel robbed of what we could and should be doing to patients. And we're looking for other alternatives. And whether that means, dispensing a Schedule I substance,
right,
helps make people feel better, give them an appetite. I remember I have a 78-year-old lady that had pretty bad cancer and chemo-induced nausea and just no appetite. I think in the course of 2 months, she lost like 50 pounds. It was stark. And it took us a little bit to get the dose right, but we finally decided to go with this sublingual oral liquid. And I was like, how did it go? And she's like, it's great. I got the nibbles. And I'm like, oh my God, that's so cute.
I love it.
That saying that you should treat each patient like family. If I could have my grandmother get the nibbles, that's adorable. For and sure. Especially I'm also chair of the clinical practice and research committee for the association, and we're actually in the process of writing up this I'm going to call it an opinion piece, but it does review the literature that we currently have, and it's specifically on the therapeutics of cannabinoids in the elderly. Okay. So it's, to my knowledge, going to be the first time that you will see a paper actually recommend THC in place of antipsychotics for agitation.
Wow.
Yeah. So I'm really excited.
Wait, I have a red flag because I was paying lots of attention in your CE and high risk, elderly in general, but also any, mental illness or psychosis or anything like that. So can you kind of differentiate that?
That's a great thing. Yeah. So I say this with any symptom, but typically for daytime symptoms, we will utilize a greater CBD ratio or product or whatever it may be. CBD itself does have antipsychotic properties. So it was actually compared in a 1-to-1 with amyloid sulfide, or I don't know, some antipsychotic we don't even use in this country.
Okay.
We are all about the second generations here, but they found that it was comparable in terms of its antipsychotic effect. But with our elderly, our Alzheimer's, those that have sundowning, when we really just want to help our patients fall asleep and kind of get into that comfortable, calm environment. I'm not saying we should, overwhelm their bodies with THC, but a little bit can definitely be relaxing, and too much can induce paranoia.
Right.
I actually joke that's probably in the next 10 years, within then, I'm imagining, we will have vaporizers that vapor herbal aroma, those things. Diffusers, no. That's what they are.
Oh,
diffusers.
sure.
There we go. So there's going to be cannabis diffusers, and we're going to be running them in nursing homes.
Oh my gosh. Oh my
homes.
gosh. Oh my gosh. I was a CNA on a dementia unit, and that would be everything.
Yeah. So you heard it first. No.
Yeah. Patent that.
I'm sure they're doing it already. You know what I mean?
Totally. So you're busy and you're really doing it. And this is, I'm like so happy to just have this conversation with you and know you, because I felt I couldn't be the only one just like in my room at night, not being able to express how I felt about cannabis, and you're really out here doing it and finding the research, because that's why I didn't want to talk about, even to have the boldness to speak out about it and support it. It's like the research wasn't there. And that's so highly, praised and valued as evidence-based medicine, obviously. And so to even talk about it in a space without having all the information with the medical field is scary, but you're making it all happen.
Yeah, I think there's a lot of backlash because there aren't a lot of placebo-controlled trials. But again, look at your goals of therapy.
Mm-hmm.
You know, there was nabiximols or Sativex or Sativex, however you want to pronounce it. When it was being studied in the United States, it didn't pass their primary endpoints, and they had to discontinue the trial early because they only found that the patients had reported subjective improvements in their spasms, whereas, you know, the objective reports, which is what clinicians could actually measure, there was no difference.
Mm.
And I think it goes to show we will never truly understand how people feel on the inside.
Right.
You know, with any symptom, any chronic illness, it changes the way you think about things.
Yes.
It changes your relationship both with yourself and with others. And you know, there are downstream implications. You know, any chronic illness, it is going to be accompanied with anxiety and depression.
Yes.
Now, again, there's some people that are really strong. They don't need cannabis. But
Right.
for the vast majority, you know, I didn't realize how bad pain could be. And I know this kind of sounds silly, but you know, after day and day, when I first started in the dispensary a month before chronic pain was approved.
Okay.
And when chronic pain was approved in Minnesota, our patients jumped.
Oh my gosh.
I want to say at least doubled. They at least doubled, but maybe not. But it was a madhouse.
Mm-hmm.
Everybody had different types of pain, and everyone was confused as to which molecule would help which type of pain. And you know, our CBD is very expensive, especially if it's a good quality and a valid dose. Like you don't want to be swallowing 200 milliliters of oil.
Right.
You know?
Yeah.
So you're going to have to pay a pretty penny, but.
And that's just, again, a plug for intuitiveness has a role in healthcare. That's what it should. We have to listen to the patient because we can't always see.
We do such a bad job at listening to the patient.
The results on paper. It's not about the objective information always. Hello.
Yeah.
I'm preaching to the choir, but
no, absolutely. Well, you know, the number of people that are on the brink of suicide because of their symptoms, their pain, to me, it's unfair. You know, knowing that we have these safer alternatives. And I think pharmacists have long been so focused on safety and, you know, behind the scenes things like you're not even going to know how much work went into getting this prior authorization approved with your doctor, but, you know, just thank your doctor, you know?
Right.
So, you know, being more in the public eye and the vision of that, you know, we need to be there. I don't want people thinking that they can get medical advice from bud tenders or gas station attendants. You know, that's unrealistic. And it's kind of putting ourselves down in the process, you know, like, as you say, it is very intuitive. It's not hard, but, you know, there are some things where it's the reason I left the dispensary full time is because I pursued a position with medication therapy management. So being able to look at the entire patient's medication list, you know, including their supplements, including their vitamins. You know, I had a patient once, you know, people ask me, have you ever heard of this thing called CDB? And I'm like, yeah, you mean CBD? Like, okay.
There's always a mispronunciation in the
I get it. It's a tough acronym. I get
it.
And, you know, I'll be like, yeah, you know, I actually do this on the side. But sometimes I don't say that. I'm like, yeah, I've heard about it. There's some studies that could help people. And then I get calls back later like, hey, we were afraid to tell you earlier, but we're
Yes.
actually already taking it. And I was like, well, if you knew it was working, like, why is there such
We
shame?
need to open this conversation. Even I was at the doctor, and for the first time today, I was honest with my cannabis use. And it's just really interesting to play the patient role and just, I want to help them. You want to help them. As MTM pharmacists, like, we just want to know it all. We're not judging you. But it's scary for them to admit that.
Oh, absolutely. And I think it's tough on doctors because I think in my perfect world, if we talk about future vision, I would like to see, I mean, I have a few future goals, but I would really like to see pharmacists in charge of dosing drugs. Doctors are just so inundated with diagnosing that they don't have time to dose and manage and follow up. And, it's thinning them out in a negative way. It's not that they can't handle it, but we're here as a resource and we're not being used to our fullest advantage or our fullest potential. A lot of the verification that goes on in pharmacies, we could do that from the get-go.
Exactly.
Save time, be more efficient. And, again, be that drug resource. People get very overwhelmed with instructions. I've had to explain how to use a vaporizer to someone probably 5 times. Like, I think that's the most people get it after 1 or 2 times. Maybe they'll cough a little bit, but then they'll figure it out.
Right.
It definitely is a little bit more intuitive, especially when you know what you're looking for. A lot of people don't know what their goals of therapy with any medicine could be. And you need to know why you're using something. I think that helps with like the mindfulness component and, some call it placebo. I call it being cost effective. So
totally. That's a good way of putting it. And so when you originally got the position, what were the requirements? Because I mean, again, there's not like a cannabis program that you go through and then you're a cannabis pharmacist.
Yeah. So my first cover letter, it was very focused on, like my clinical expertise, like, oh, I was doing a rotation here. And, this is my first job. So I didn't have actual pharmacist experience. So then the second one, I really pushed this project I had done when I was an intern. It was when I was I think they call them pharmacy interns, like when you're working in a pharmacy.
Yeah.
Anyway, so I was working for this independent and I was helping get their Medicare Part B program up and running. So just the paperwork and compliance of that, like I pushed that and they're like, oh yeah, she can like read things well. I'm like, yeah, that's what I touted. But
cool.
The requirements were very simple. It said you must have a valid Minnesota pharmacist license in good standing. And then the second thing was, how did they say it? Active in pharmacy for the last 5 years. So at first I said no as well. I was like, well, I haven't really been a pharmacist for 5 years. And then I said, you know what? I'm going to say yes. I'm going to get through that screening process. Yeah. And they never brought it up. They knew I was new. They knew that I was still in, like, I didn't have my degree and I could only start at a certain date. And, they were very, very accommodating. So
yeah, that's awesome.
It never hurts to, be good to yourself, be nice to yourself. Don't put yourself down when you're doing interviews or anything. Be proud.
Totally. Oh my gosh, I'm loving this conversation. So then when you were on the job, what was the training like? Because then you did have to have, I mean, again, I'm talking about how intuitive it is, but we like evidence. We like to know what we're doing as well. So how did that come in?
I think I shadowed 4 days. So it was like a Monday, a Tuesday, and then the next week, it was like a Monday, a Tuesday, and then a Friday and a Saturday. And then they let me go on my own.
Wow. Whoa.
Yeah. So, a lot of it, I'd say, I always try to focus on what's really important here. So for me, really important was keeping track of the inventory. I felt like it was my license on the line. And, sometimes at the end of the day, not going to point any fingers or name any names, but you might up one product and down another. And it's like, oh, shoot, let's dispense that. And then you give the patient a call and then they argue with you. They're like, no, this is right. And I was like, no, I know I messed it up with you. Like, can you please fix it? And they're like, I was like, can you please just confirm? And they're like, no, the font's too small. I don't know what I'm looking at. And I'm like, I'm like, no worries.
Fine.
So yeah, the responsibility of, managing a controlled substance, I think we're pretty comfortable and familiar with it.
Right.
We're, taught how to use the DEA and operate within that scheme. And then the other thing was, of course, the patient consultations. We call them appointments.
Okay.
And, the goal was to have you the first time visit where you go through, you're supposed to go through the endocannabinoid system and phytocannabinoids and which one we'll be using for their specified goals of therapy and all the formulations we have. And by the time we got topicals introduced, the topicals were approved by the state, we had like over 90 different types of products in the vault. And I would literally spend like 40 minutes counting it all twice a day. It was like,
whoa, that's so,
yeah. And I'll tell you,
didn't even think about that aspect.
it was so many, because then we had like unscented topicals and scented, and I was like, oh Lord. Okay. And then the whole vault smelled like lavender and linalool. So.
Right. Wow, I didn't think of the inventory at all.
Yeah. So you get faster at it. But when I first started doing consults, they were like an hour long each, and I was super late all the time. And then I started to get faster. And then I thought, well, why not just record my voice?
Yeah.
And I recorded my voice. And then I was like, let me just make like videos with this.
Dope.
And I think a lot of the people liked it, especially because they could like talk to me right after. So they're like, oh my God, this is the same person.
Right.
Or like even better, they're like, hey, we watched your video before coming in. And I'm like, great, what do you want?
So then after the initial visit, so from my understanding, because I'm actually from Minnesota as well.
Oh, wonderful.
So my understanding is that you have the consultation, but they end up selecting the product that's right for them. Or
it's collaborative.
Okay.
I've definitely, so I'll give an example. There was that first week that I was working, right? And I have my first pain patient, and we have this like online registry where it has like their baseline medicines and their other medical conditions and their goals of therapy, whatever. It's like very, very expansive, like survey.
Okay.
And I noticed the birthday, and I'm like, oh God, he's 13. Like, why is my first pain patient?
Oh, no.
It should be like, a back pain. So I get a 13-year-old that's apraxic, meaning he doesn't speak. Okay. And he was severely autistic to the point of self-injurious behavior and very violent with all of his caregivers, his parents, himself. So I was like, let's do this. And she's talking to me. The mom is there, and she's talking to me, and she's like, I really want to go down the CBD route. I'm like, we can go down the CBD route, but I don't think it's going to help.
Totally.
Especially if he's having like an episode. So I learned how to use proper terms, because, every condition describes their symptom differently.
Right.
So no, you try to be like all encompassing and inclusive. But anyway, so I told her, I was like, okay, I'll give you the CBD, but I highly advise you take some THC home. That way, if you don't need it, don't use it. Like, what have you got to lose? You've tried every other pharmaceutical on the market. It hasn't worked. And that's the thing. Like, people will go to cannabis as a last resort. Right. And it boggles my mind.
Can we reverse that, please?
Yeah. Like, this should be a first line therapy for
Definitely.
So many things. Like, it's so easy to use. We have such flexibility with dosage forms. Like that. I'm so grateful for that. Like, that's exactly what we need with any drug. Like, any way you want to administer it, you can.
And so a couple things on terminology. I want to bring that up now. First of all, you and I both use the term cannabis. So let's stop using marijuana. I think that would be step one for anyone in the healthcare industry. If you're still using the term marijuana, unless I guess you're, in a Spanish speaking country.
I did some research on the term marijuana.
Tell me more.
Yeah, because I was doing a presentation in Montreal, and they call it marijuana. And I found that, traditionally cannabis as medicine was used as an extract. So it would be extracted in alcohol or oils, and then that would be dosed, with some type of liquid measuring tool. And it changed in the 1920s or so when Spanish immigrants came over. Hispanics is what they called them. And they associated them with the smoking of the leaf, which they called marijuana. So they saw the two as physically distinct, kind of like how we see cannabis and hemp.
Hemp is different plants.
So like we're still guilty of it. Okay. Is what I'm saying. We're not out of the woods yet. But it truly, has that thing. And I don't like to use the word marijuana unless I'm referring to something that I cannot tell you what is it. If I see, I refer to it like when my patients use on the street, like they don't know what they're getting. They don't know where it's coming from. They don't know how it was stored. They don't know anything about it.
You don't have rec. So that's, yeah.
Oh yeah. Yeah. So, right. Yeah. It's tough, but like I'll say, like there's a lot of state programs for medical that have marijuana in their name. The Pennsylvania marijuana, like that just drives me nuts.
And that gets really tricky because they will use those terms as loopholes, whether they put cannabis in the law or marijuana.
Yeah. Minnesota's super strict. We can't use that term at all. We also can't use like the pot leaf in any of our advertisements. We can't use any strain names. And as a clinician, it's great because I don't care. People tell me, well, I only like Blue Dream from this dispensary. I'm like, okay, you know how silly you sound right now?
Yeah, totally. Did you know, you probably did, but I just learned from Dr. Sulak the other day that we are supposed to be calling them chemovars instead of strains. I'm loving this.
I think it's short for chemical variation because that's what's important. I don't care what it looks like. I don't care what its parents are. I mean, I'm all about genealogy and ancestry, but come on.
Exactly.
With cannabis, I did a presentation. So I had to do my research. I called it Beyond THC. So like the molecules beyond THC. And I learned about like how you can manipulate the plant to get the different colors you want. And how people like crossbreed these, are they considered genetically modified organisms? I have no idea. There's so much misinformation, disinformation, whatever you want to call it, fake news.
Yeah, it's an interesting time. It's like the Wild West and you have to be really careful about your sources. I do want to hear about your favorite resources, but I do want to mention one or two more things about the terminology that I picked up in your continuing education. One was just being specific and consistent with terminology as professionals. And you use the term inhale instead of smoking. And then something that also struck me was using the term impairment or intoxication instead of high.
Yeah, I rarely, if ever, use the word high. I just find it such a triggering word for so many people, and it doesn't really have a definitive, like concrete meaning. So it just like causes more questions. Like so as I mentioned, sometimes my consults go over. So I very quickly started to adopt group consults because I thought, the education is the same. I'm going to teach everyone the same thing.
Yeah.
Like, if they don't get a vaporizer now, I want them to know it's the fastest acting and the shortest duration. And, in this process of group consults, sometimes there'd be people, I try to group conditions together so that people weren't like awkward.
Right.
But, there'd be times there'd be like, a 20-something-year-old and then like an 80-year-old.
Cute. And it's bringing everyone together. It's so sweet. I love this plant.
It's great. And then, I find like the 50, 60-year-olds, they're more like apprehensive about it. They're like, what do you mean it's mind altering?
Right.
It makes me high. I'm like, yeah, if you want to be high. No,
exactly. You're like, no, scratch that.
I actually used to say, every single person, whether they're using it for medical or recreational purposes, deep down, it is for a medical purpose. I said, everybody's self-medicating something.
Agreed.
And then I had somebody come up to me after that talk, and they're like, I just want you to know, I like getting stupid. So I don't know what you think I'm treating. And I was like, I don't diagnose.
You're like, that's not my role.
I'm like, I don't diagnose.
Oh my goodness. So what are your favorite resources? Who do you trust when you're looking for information?
So I really like Health Canada. They have a monograph for healthcare professionals. If you type in like Health Canada, marijuana, healthcare professional, it'll come up, and it's from 2013. I think they updated it in 2015, but it is so I feel like it's 300 plus pages. Like it's so comprehensive.
That's the
I think there's over like 1,000 references.
Wow.
And it falls in line with how I like to educate on cannabis, like therapeutics. I really believe you need to know how the system is in imbalance, or, what's wrong? What's the pathophysiology here? And how can cannabis be used to mediate that? And I think, a lot of people just assume that cannabis just decreases, other things, but it doesn't do that. It can also increase. It's a modulator. So it doesn't just do one thing. It regulates that amount of energy, and it's supposed to be functional. And when there's things that go wrong with the endocannabinoid system, we see that. And it makes me wonder, for a lot of conditions, migraines, irritable bowel, fibromyalgia, why are we just masking the symptoms?
Right.
Like if we actually compare cannabis and our disease modifying, anti-inflammatory immunosuppressants, it's night and day difference. However, not everybody will tolerate them.
Mm-hmm.
And so another resource I like to use, I scan PubMed. I should be doing it more often, but hey, that's what students are for.
Hey.
So, our organization does accept students, and they do so much for us. And, it really gives me hope in the future because there are future healthcare professionals. And so I also like anything that Dr. Ethan Rousseau publishes.
For sure.
I will reread his articles as a bedtime story to my kids. No. Let me tell you about the entourage effect.
Yeah.
He's actually the one that was first to describe clinical endocannabinoid dysfunction, or he called it deficiency, but I think a lot of the healthcare community is kind of more aware of a dysfunction, meaning it could be a surplus or a deficiency. And cannabis can modulate that in either way.
Could you, just as a little science lesson, could you just explain the biphasic property of cannabis?
Oh, absolutely.
I don't know that everyone knows that, so I want to put it out there.
Yeah. So this is not unique to cannabis. Okay, this happens with a lot of drugs. But with THC most specifically, we can see, anxiety relieving effects. We can see improvements in nausea at lower doses, whereas higher doses are more likely to trigger those symptoms or those issues, those side effects. So it's kind of like this idea that there's a maximum allowable benefit between certain dosing ranges. So that's why we recommend start low and go slow. It's very easy for some people to overshoot their anticipated dose, and you can't tell just by looking at someone.
Right.
Every now and then I'll have an 80-year-old that weighs 100 pounds. She's on 25 milligrams of THC twice a day, and 25 milligrams in a pill is not 25 milligrams in an edible, because that sugar that directly blocks your absorption of THC. So I don't like dosing candy or popcorn or anything like that when it comes to medicine. But so biphasic, super important. We can probably see it with seizures as well. I give the example for my adults. I probably wouldn't do this in my kids unless there was THCA. But with THC, if our adults are having seizures that are triggered by stress or lack of sleep or whatever have you, and cannabis is used to ameliorate those concerns, and we have no triggers or no stressors for that trigger for that seizure, from my perspective, that is in and of itself an anti-epileptic. So but in high doses we can definitely see THC trigger seizures. So we do want to be careful with the right dosing. Talk to your healthcare professional. Hopefully they've heard about it before.
For sure. Yeah. So what's one of the most astonishing cases you've been a part of that you've, a turnaround?
Yeah. So we had this patient that was in the program. I have two. Can I tell two stories?
Yeah.
I'll do a male and a female. That way I can give you both perspectives. Both will be for pain though. Okay. So my first one, I was picking up shifts in another dispensary out in Rochester, Minnesota, which is where the Mayo Clinic is. So you are bound to run into some pretty cool things over there. But I had this guy who was going in he was a cartoonist. That was his career. And he was going in for some routine surgery on his elbow. And the surgeon nicked something and it completely cut off his nerves to his fingers. So he had, his from the wrist down, no feeling. He could still move his hands, but he just couldn't feel it. And then that kind of went down, a spiral. He wasn't able to work, went into a depression. I believe there was some substance abuse disorders. And the nerve pain was he got diabetes, he got diabetic neuropathy, so his feet were buzzing, and it just kind of went from there. So he comes into the dispensary for pain, and I think he was in the program at the time for like 2 or 3 months. And I asked him, I'm like, you've only ever gotten one thing here. And you come in like at the same time, like, I know you're taking this every day, but like, is it helping you? And he's like, no, like I'm still waiting for it to do something. I'm like,
No.
do you feel anything? He's like, no. I'm like, increase the dose. And usually people will come to us to be like, look, I don't want to spend all this money if it's not working,
Yes.
So I was like, wow, why didn't this guy just come to me? So I started working more shifts there, consecutively, and I ended up seeing him again, and he's doing better. He wanted to tell me he's already off one of his gabapentin.
Yay.
I was like, great, not a goal of therapy, but never hurts. And then I wasn't there because then it like turned winter time, and I don't like to drive 2 hours in the snow. And when I saw him the next spring, at this point, he was like telling me all his good news. He, I call him up to the window and do like the selling of it, and at the because he didn't know I was going to be there. It's not like we give our schedule away. And he comes up there and he brings me this piece of paper. He goes, I drew that for you. And I was like, oh my God, like what? And he's like, I have the feeling back in my hand. And I was like, that's amazing. And he's like, I learned that this giant imprint in the center of my palm is from my cane. He had no feeling in his hands that he didn't realize his cane was uncomfortably like rubbing against his hand.
Oh no.
To the point where sometimes there'd be blood and he just didn't put 2 and 2 together.
Seriously.
So
awareness.
Yeah. So that was a great one. I had another one who had mast cell activation disease, which is basically, I joke, it's not a joke because it actually happens, but she would get like anaphylaxis in my waiting room.
Oh no.
And if she was at home, she would just smoke some weed.
Exactly.
Knew that it kind of worked. And she was over at another dispensary and she was in the program for like 6 months. Nothing happened. Like nothing changed. She was very frustrated. And they were giving her like a bunch of CBD. They're like, CBD is anti-inflammatory. Like this is what you do. Like just let it work. And I'm like, oh my God, like are you still, and I think I looked at her honestly. I was like, are you still smoking weed?
Right?
She's like, yes, I am. I was like, all right, let's get you some like medical grade THC. Like we'll get you on a stable regimen. And, within 2 months, I got her off of, so she also had Ehlers-Danlos syndrome. She had fibromyalgia. She had this mast cell disease. She had depression and she had ADHD meds. So she was on like 15 different drugs, and she would have to take like Claritin and Benadryl and Libra, like steroids, like all day, every day. And within I think it was within 2 months, she was like off of all of her meds. And it was amazing. We transitioned her from vaping because we don't smoke in Minnesota, we vape.
Right.
Bougie. So we transitioned her to like pills and she was able to control it.
Amazing.
And she comes in and she's like, I'm like, what's going on? Like usually people make appointments when they need my help. Like people don't just like make an appointment to be like, hey, how's it going? So I was like, oh, what's up? What can I do for you? And she's like, my husband and I are ready to start a family. What do we need to do to continue in this program? I'm like, well, first of all, thank you for asking.
Yes.
Because my license is on the line. So thank you. And secondly, let me talk to a lawyer because I have no idea. But she comes to me and she's like, look, I was able to get off of all these meds. She went and looked up the pregnancy category of each and every drug.
Whoa.
She's like, Paxil, that's a category D. She's like, I know you know what that means. And I'm like, I do. I'm very proud that you like spend all that time because now I don't have to.
Yeah. And like empower the patient. Do your own research.
It was like a full page of the drug that she was on and why, and the pregnancy category. And I kept it. I took a scan of it and I uploaded it to her patient profile because I thought it was super badass.
Yeah, good for her.
And finally, my chief medical officer gets back to me and he's like, all right, have her sign these waivers. Make sure you like reach out to the OB and like the primary. And I'm like, all right. And then, healthy baby. I was actually due 2 days before my birthday. And I was like, please just hold it. Just hold it.
Yes.
No, I didn't say that. I said it to her husband.
Honorary. Baby.
Yeah. And so, in that situation, we did talk about like, let's not vape or smoke.
For
Let's just
sure.
like the oral stuff and try to like, be more proactive about our dose. And I was curious to see how the dosing would change because, there's some pharmaceuticals where we do need to adjust the doses when someone's pregnant. You're
Right.
bigger. There's more blood. There's, all these different things that are going on. And we actually lowered her dose significantly as she was stable on 10 milligrams. And she ended up taking 2.5 every night. Some nights she would take 5, so she'd take 2 pills. But
Sure.
overall, it was definitely lower than what she was doing.
Amazing.
Really cool.
So
we need
great.
more studies,
Yeah, totally.
Like we need more studies. And it's like, okay, well then petition the DEA because this is not a Schedule 1 like substance. Most of the psychedelics and the psychotropics that are in Schedule 1 should not belong there.
Yes.
And I think our government is just using Schedule 1 as a means and a mechanism for, this failed war on drugs.
Yeah, totally.
You were at the Pharmacist Moms CE, right? Yeah. So I think I put in there like how much we are spending on our federal government, what we're spending on just prosecuting for marijuana. It is asinine. It is in the billions. Billions. Like who's in charge of this? This plant is here to heal communities. That is why it is here.
100%.
To be grown in community gardens. Yes. I'm all about local. I actually get into little riffs with other healthcare professionals because of my views on home grow. I don't see it as a viable pharmaceutical alternative. However, doing it for other things, I totally think people should have that right to do so.
Grow that. Yeah, definitely.
To grow their own. Absolutely. But, if they're not able to find consistent, successful results for their clinical outcomes, they should definitely talk to a healthcare professional because there are better alternatives. People don't need to suffer anymore.
No.
Hope that the field mice get into your stash. Like, I don't even know.
Right. Do you think that it will ever be covered through insurance? Like, how do you think we'll navigate that?
I'll tell you now, I have workman's comp in Minnesota. If you bring a case to a judge, they will cover it.
What?
Yep. I have had numerous people. I think I'm at like a dozen right now that have gotten their cannabis successfully reimbursed. They don't like pay for it up front.
Right.
You got to put the cash down, but you can get it back. And then the other group I've seen is with commercial plans. So not Medicare, not Medicaid, but I've had commercial plans with commercial insurers who reimburse.
And we're not talking Epidiolex. We're talking...
Correct. So they've reimbursed like cannabis products. Ideally they do it for like seizures. I think I had one patient who was able to get it reimbursed as like a hospice related expense.
Okay.
I have no idea how she did that, but I think I asked that one. She's like, oh, the mom, she's like, oh, I work in insurance. And I was like, all right, I know what you did.
Mom. Yeah, mom. So I also like to ask each of my guests, do you want to share an edible story? We all have an edible story.
Okay, so I will share one. And I'll just preface this with my dispensary sells very precise ratios and milligrams. And every single product we have that has THC, I'd say most of them, they have the standard 2.5 milligram dose of THC. So for example, our 1-to-1 is going to be 2.5 of THC and CBD. Our THC dominant is just the THC. And then our CBD dominant has the 2.5 milligrams of THC with like almost 50 milligrams of CBD.
Okay.
So I'm out in Women's Grow in Denver for their like national leadership conference. And I'm like blown away by the success and the vitality of these speakers that are involved in cannabis and just their journeys there. It was so inspiring. I truly recommend it. There were men in the crowd. It's very nice.
Yeah.
All inclusive crowd. And then they give you like this voucher for like I don't even know what to call it, like a goodie bag, I guess is the term. And in this goodie bag, I you go to a dispensary and redeem it. And I found this it was like a thing of chocolates. And it was like 4 squares and they were 2.5 each. Well, it said 10 milligrams total. So I just did the math. I have no idea because it's chocolate if it was actually mixed and, cooled properly, but we'll hope. So I eat a little square and first I had half a square. I'm like, that is delicious. You
oh no.
Flour. So I had like one full square, which is 2.5. I kid you not. I don't even know how much time had passed because my perception of time was so altered.
Right.
But my eyes were so dry. Like I couldn't drink enough water. My mouth was so dry. It was awful. And after that, I was like, I was like praying to go to sleep. I'm like,
yes. No, what a bad experience.
I know, I hated it. So then I stopped giving people THC.
No.
But then I realized, we all have different levels.
We're all different.
We're comfortable with. We all have different levels of impairment we're comfortable with.
And it hits you differently depending on.
It does. Especially, looking at the route, is it coming through the mouth and under the tongue, or is it going through the intestines? Is it going through the skin? I'd like to see more products come out that are transdermal. I think there's a huge population, a huge vulnerable, dependent population that could benefit from that. So I'd like to see more studies. We don't even know if it gets systemic absorption. We have no idea.
Right, exactly. I have some hookups for you. We have to maybe connect again after this.
Oh, absolutely. You're in where? Colorado?
Yeah, we're in Boulder.
Where everybody I went to high school with now lives in Colorado.
It's the best. We'll see you here. Oh my goodness. Thank you so much for sharing. So just to drive it home, where do you see a pharmacist's role in cannabis?
We should be at the forefront. This is a means as a quality of life reducing agent. And as healthcare professionals, we are here to provide compassionate relief. So I encourage you as healthcare professionals, as concerned citizens, as patients, do your research, keep an open mind. I think another thing I see, especially online, is, people that may have cured their cancer or, may have completely changed their life around, and they're so blinded by their success that they don't understand that not everybody is in that boat with them. And those are the people that really need us. So anything we could do to, help humanity evolve, I think as pharmacists, as the druggists, as my old patient
is the druggist there?
Yeah. Are you the druggist? I'm like, yes, but I don't work in a pharmacy. So it's here. It's not going anywhere. If anything, I think the FDA right now is discussing, should it be a Schedule 3, meaning you can put pills on it. In my perfect world, it would be behind the counter. Yes. So if you wanted to speak to a pharmacist, you could, but I see THC and CBD obviously, but THC especially. I see 2.5 and 5 milligram oral preparations available, probably if not next to Tylenol, replacing Tylenol.
Yes.
Just because of its safety profile. But, I will kind of back up and say cannabis isn't that good for acute pain. So
okay.
Chronic pain is different, right? There's that psychosomatic component, that psychological, spiritual, if you will.
Totally. Yeah, I'm with you on that. This has been so enlightening, and I really could talk to you for 4 more hours, and I hope that we're friends now because
definitely.
I have a lot of questions for you. We got to keep this up. Maybe you'll be a recurring guest.
We follow each other on Instagram, so we're happy.
Okay, honestly, this was so amazing. Where can the people find you? Do you want to plug anything? This is your moment.
Yeah, so if you are involved in the industry and you'd like to get connected with any cannabis pharmacists in your area, or if you are a pharmacist and you want to learn more about cannabis pharmacy, visit our website at ascph.org. Sometimes we say ask your pharmacist if cannabis is right for you. And then we have some education available there now, some continuing education that is accredited for pharmacists. So super excited that we have the support from our institutions to do so. And sign up for our newsletter if you're interested in PrepCann. There's different courses for healthcare professionals or dispensary staff or even caregivers. So if you work in an institutional setting or if you have a loved one you're considering cannabis for, definitely give it a view, see how it can work for you. And as I mentioned, keep an open mind and keep the prayers coming.
Yes. Okay. You're an amazing being. Thank you so much for being on this show. And I'm going to sign off.
Thank you. Bye, everyone.
Thank you so much for tuning in to Cannabis, the podcast. Don't forget to subscribe and give a 5-star rating. You can find more information about mindfulness and what I do at tidytor.com. Follow the Cannabis over to Instagram and connect with me through direct message anytime. Big love.